Hello, Instagram and YouTube. Hopefully you can hear me. I am just currently attempting to live stream on both YouTube and Instagram for the first time. Probably not wise since I'm by myself in the studio and there's no one here to help me with technical things, but I'm going to do it anyway. So thank you guys. I can see people joining on both channels so far. So I'm currently live on YouTube and Instagram, and we're going to take your questions on complications. So basically anything you want to throw at me, I'm going to do my absolute best to answer all those questions. And obviously what I noticed from the comments is that many people are particularly focused on, as you'd expect, vascular occlusions. Let me know before I dive in, can you guys hear me? That would be the most important thing. So I can see someone has joined from Korea. Hi, JJ. Can you let me know if you can hear me? I always like to double check that. And guys, on Instagram, can you hear me as well? Layla, you can let me know. Yes, you can. Okay, great. Loud and clear on both channels, which is fantastic. So this is our first time ever doing a live on two streams, and particularly on YouTube as well. So hopefully it'll be entertaining for you, and we can deliver some insights into what I've learned about complications over the last 15 years. I know it is a big barrier for people when they first start, and then it can catch people and limit them as they go forward. And one of the things I love to help people do is to overcome those little glass ceilings that get in your way so that you can go forward and do great work. Thanks. A lot of nice comings. Yes, this will be recorded. I will share it again. I'll save it onto the stream so that you should be able to get it onto whichever platform you're on. You should be able to see it in the future. Okay, so everyone can hear me. You guys can drop in the questions as they come to mind. I'm going to probably take most of them from Instagram, and obviously you'll hear them on both sides, but I'm going to answer them as we go, see what comes up as the most common questions. Okay, so they're coming in so thick and fast. It's hard. It's hard. It's hard to catch them all. First one I'm saying, tell me something about vascular occlusion. So if you're injecting, the reason vascular occlusions are the one that we worry about the most is because they're the one with the time limit. Like everything else you can think about for quite a long time, but vascular occlusions, ideally you're gonna identify them immediately and treat them comprehensively within a short time frame. And that's actually the thing that makes them harder. I'll be honest with you, if you ever get a patient with an infected filler, it can be more stressful and go on for longer than a vascular occlusion. But everyone likes talking about vascular occlusions because that's the thing you really are limited with time. So my top tip with vascular occlusion is build in systems into your day-to-day practice that make you good at picking them up early, because an early diagnosis is one of the easiest things you can do to make it safer for your patients, because everything else is easier to do when you've got time. So early diagnosis, that means checking capillary refill with all your patients and in between individual injections is going to give you your best chance of picking up the diagnosis early. And that's the thing that makes everything else easier. The next thing is also to make sure that if you do get a vascular occlusion, that it's not a huge vascular occlusion. So small injections, you can do little safety checks between injections. Just basically, the more you're putting into high-risk areas, the higher the chance that you can have a large vascular occlusion. And if you have a large vascular occlusion that's delayed late, that's the worst thing that's basically one of the worst situations you can find yourself in. So we want small vascular occlusions diagnosed early, and then you need a clinician who's prepared to treat them. So not only are you diagnosing early, and you're injecting in such a way as the actual occlusion will be smaller, but you're also prepared for it. So early diagnosis with a prepared clinician. If you've got those three things functioning, those three factors are in the right way, then you're already massively on the safer side of the spectrum. All of the worst injuries I've seen have been delayed diagnosis with large injections. Those are the ones that get us all on social media and get us all into a tiz and make us feel afraid. And the truth is, if you're good at injecting and you've built those other things in, that should be extremely unlikely for you. I've also been, just to give you some reassurance, I've been interviewing clinicians that I've been coming across at conferences and things and asking for the record of how long anyone has gone without a vascular occlusion. And so far, it's 35 years. Like, this industry is not really even 35 years old, but I know I've met one injector at the Inner Circle in Switzerland who'd been injecting 35 years and had never had a vascular occlusion. Now, that clinician was doing all sorts of things to prevent and diagnose early. So it is possible that you could go through a whole career without having a vascular occlusion. But a great saying I picked up recently, it's I think it might be Charlie Munger or Alex Hormozy says it, but the advanced person isn't doing loads of crazy stuff. They basically do the basics all the time. So can you be consistent with the basics? That's how you become a really safe injector. So that means every single time you inject, you do all the steps, all the safety checks. That's what makes you, and all the thinking, that's what makes you a really advanced injector. It's not necessarily the breadth, but the systematic way. It's like a pilot who's flying. They don't just do the safety check in training. They do it every single time, no matter what. And that is actually the heart of being a safe injector and not having to worry about complications, is that you do the basics every single time. Okay, so that's a kind of good top level to go through, but let me pick a few questions and see what I can get from you guys. Okay. Okay, lots of questions, lots of comments about Miranda's recent comment on her post. Oh, that's funny. It's weaving my stories in with the Instagram live. So I'm going to go from the comments instead. So, do you think that injection with hyaluronidase is better if you inject at the same way as you injected the filler? So, let's picture a vascular occlusion. If you've just slid the needle into position, injected in such a way as you've blocked the artery, it does make sense that a repetition of that injection is going to have some likelihood of putting the hyaluronidase exactly where the blockage is. And of course, blood vessels branch out and they spread, and it's possible that filler can flow in either direction in them. You can also get emboli, although I think that's probably less likely than the main bolus blocking it. So I think that's a very reasonable thing to do as your first pass when you have a vascular occlusion, but I wouldn't rely entirely on that. There's a stage after the early diagnosis, which I call the comprehensive diagnosis. So once you know you've got a vascular occlusion, we then need to think about how big this vascular occlusion and where it might be affecting. And this you can think of, it's a little bit like an earthquake in that there's an epicenter, but there's also the degree to which the damage might be done. So you need to think about how broad is this area of tissue that's occluded, and also how deep is the area that is the occlusion. And both of those elements need to be done correctly for you to know how to dissolve it. And then once you've got those two elements, you'll know exactly where you need to inject. The problem with only injecting where the offending injection went in is that you're quite isolated to where that is. And if you're not in the vessel again, which may or may not work in various ways, then you might just be injecting near the injection point, whereas the filler has flowed away from that point. So you can do that once in the early stages, but crucial in the first 30 minutes of a vascular occlusion is to spend time paying close attention to how broad that the affected area is. So I'm continuously doing capillary refill and using much more than just I like to get the detail with a cotton bud or a finger, but it's actually very helpful to compress the whole area that might be affected like this. Say it's on the lip, you'd compress the whole mouth and then watch where the blood flows, because you often get a clearer idea of where the delay is. And it's often very surprising. It's not exactly where you anticipated it to be. So that's stage 2. Stage 1, inject where you injected. That's reasonable. Stage 2, map out the area superficially. And then stage 3 is to look for potential deep areas that could be affected. So if you've injected lips, check the gums. If you've injected noses, check the gums. Look inside the soft. You can have a look at the soft palate, the hard palate. I meant more likely the hard palate be affected than the soft palate. Also look inside the nose and check the septum. You're basically looking for the deeper areas that can be affected that are harder to see initially. So I remember recently, Dr. Amy, not recently, it was a couple of years ago now, but Dr. Amy at Skin Viva helped with a patient who had a nose job, injectable nose job, and initially had lots of pain, but capillary refill was normal. Now, she looked inside, she actually noticed that his septum had necrosed. And this is exactly the kind of case that we need to be worried about. It wasn't one of our patients, as we always have to say. It could have been one of our patients, but it wasn't. Is that you need to think about the depth, not just the superficial nature of vascular occlusions. So mapping out depth and spread of VO will help you decide where to inject. And once you've discovered that there are deeper areas, you can inject there as well. Okay. Let's have a look for another question. So someone has mentioned that they had a tiny injection of zero point 0.2 mils that turned her lower face black, nose and cheek. Hopefully that was more of a bruise than a necrotic injury. Sounds terrible though. I hope you recovered well. Okay. I had my first ever filler infection on Sunday and now on antibiotics, but how stressful it is, I could not sleep. I feel my confidence has gone to pot now, even if I had to tackle a VO. So it's worth knowing the first time you have any complication and you've not dealt with it before, you are completely out of your comfort zone, because no matter what you've learned about this on an intellectual level, it's different actually having to deal with a patient. And this is something I go into in depth on one of my webinars. You probably, in fact, Layla can drop the link into this. I'm doing a webinar tomorrow night that covers much of this side of things. So in order to understand the emotions around complications, you have to think that complications are very different in aesthetics to what they are in the rest of clinical medicine, because in the rest of medicine, you basically deal only with those things. Whereas what we have in medical aesthetics is a healthy population of people who hopefully don't have problems. And when they do, it's so much worse because they're generally healthy and they just wanted a positive feeling. And you're all of a sudden dealing with something medical that's complicated and can go on for a long time, and it's on the patient's face. So it's more upsetting than many of the diseases that I deal with as a GP, because it comes out of nowhere in a healthy population and it's very, very visible. So it's very stressful. But every time you go through a complication, you will get better at handling it, to the point where now there's two routes I see clinicians go down. One is, if you're basically, the way I was very stressed out by complications, but I put the energy into learning how to handle them, and then it actually becomes a place where you can bring some order to the chaos, which is quite a nice feeling, and you can even start to enjoy helping with complications. The other route is complete desensitization, where you just say, well, it's par for the course. And you do get clinicians who are a little bit like, well, you're going to have VOs, you just have to accept it. I'm not going to get too stressed about it. When they come, I'll do my best. Now, I prefer to maintain my fear of them and put the energy back into the system to prevent them, because, and I don't know what drives people one way or the other. I suspect most people are closer to what I'm like, which is that you feel terrible when your patients are injured and you can't, like this clinician has said, you can't sleep because of it. But that's an energy. Like, that really is an energy that you should drive back into learning and practice and communicating. And everything you've learned with this patient who's had an infection becomes something that you talk about in your consultation. It becomes things that you do extra in your procedure. It becomes part of your aftercare. And that's the real secret to driving the stress into creativity that makes you a better, or work that makes you a better clinician. So that's the main thing I say to you is, in every complication, there's a ton of learning and experience that you can feed back into the system, and it makes you better if you use it. Don't let it put you off. Use it as an energy to actually do more. But I'll let Layla drop the link in, because the webinar I do, if you've not seen it already, covers this concept in detail, and it really is the route, I believe, to using the anxiety as an energy. Okay, let's have a look at some questions from YouTube as well. Okay, what would I do for a patient who wants lip fillers but has had in the past a history of swelling from hyaluronic acid during the lip augmentation? So reactions to dermal fillers are not super common, but they definitely happen. And some patients just swell more than others. So I remember I had a member of staff for ages who would have treatment, and she would always swell significantly for the first hour, and then it would settle with no other intervention. And she loved her treatments, and it was okay to do that. So it is okay to treat people who just swell, but it doesn't persist. Now, if someone has an allergic reaction, that's really different. So, and it's particularly if the filler goes lumpy and hard, and you end up with delayed onset, or it's not even delayed onset, often it's within the first couple of weeks, that I consider a reactive case, and I do not retreat them. Now, I'll be honest, I had a patient in the early days who just loved the results of her lips so much, and she really pushed me to just try another hyaluronic acid. And I reasoned that, well, it's a completely different product. I know it's hyaluronic acid, but hopefully it'll be okay. And she was happy with the fact that I didn't know, and it was a bit of an experiment, but she reacted again. And that was devastating for me. I really felt awful having repeated the procedure and got more lumps. So that was the last time I ever tried switching filler on someone who'd had a clear reaction, because we just don't have any data on it. I don't know for sure if it's different brands or if it's just hyaluronic acid, and I think it's quite a tricky situation to know that someone's reacted and then to retreat them again and for them to have the same reaction. And I decided that was too risky for me. That happens to be my particular risk profile, and I always say to injectors, you need to do things that you feel comfortable with so that you can sleep at night. Even if other injectors would do something different, that's fine. But at the same time, I do encourage people to not hide from all risk, to manage risk instead of hiding from risk. But my position with that is I don't see how I can. I certainly wouldn't do a full augmentation on someone who's already had a reaction, but you need to make the decision about whether this was just post-procedural swelling or whether it's a true reaction to the product. And if you're not sure, you could potentially do an intradermal test. I've certainly had a couple of patients I've done those with where you can feel that filler is harder than it should be and it's a little bit red afterwards, and that I would consider as a positive, and I wouldn't treat them again. Okay. Here's a question. While giving botulinum toxin near the corrugator superciliary, if by chance we enter the supratrochlear artery, will it travel to the levator pulmonary muscle and cause ptosis? So if it enters the artery, and you will enter arteries with Botox, it's worth paying attention, particularly when you're injecting foreheads. Occasionally you'll see a flash where you just see the botulinum toxin enter a vessel and you get a white area that then disappears quite quickly. This is something that when you notice, you'll pick it up maybe once every 4 months in a busy clinic. I'll see it. And that is something that you don't need to worry about if you've injected small amounts of botulinum toxin, because it's being flushed away from the eye and it's being put into the systemic circulation. So you're diluting that. It'll go through the veins. It'll then get mixed up with the circulatory system, and there isn't enough in it to make any serious, to cause any serious side effects. The problem might be if you were not in the vessel, but it goes through the foramen, because that is quite a direct path into the orbit. So if you're injecting deep near a foramen, I think there's, in theory, and I've done this on cadaver labs, it's actually surprisingly easy and surprisingly close to get into a foramen. I think typically your patient would jump because you're going to be close to the nerve as well. So I don't think it happens all that often, but depth around, particularly around the insertion point of corrugator supercilii, that is the worst place for you to inject deeply, just above the eye here. So I always start relatively deep medially and become more superficial as I go laterally, and that is the safest way to inject. And you should enjoy many, many years of no ptosis if you do that accurately. Think about where that muscle is very carefully. Inject the middle of the muscle or above it, and don't just inject the area, which many injectors do, because it's not actually even mentioned on the license what dose to treat at. It just shows you the injection points. We need to think in higher resolution to lower your risks. Okay, let's have a look at another question. Can I recommend a product for use in lip filler for a patient that has an allergic reaction to HAs? I don't know. I only use hyaluronic acids for lips. I don't know any, unfortunately, that you could use instead. Let's have a look back on Instagram. Someone says, I had my first positive aspiration on Friday, terrifying. I would say you should actually feel reassured, because so if you have a positive aspiration, you have data before you inject that you're near a vessel. You've just got information that you can use to make a decision. So you did exactly that. You used that data and you didn't inject. So you should actually feel reassured that there's a way of finding out whether you are in close proximity to a vessel before you inject. If you're not using an ultrasound, it's the best way possible that I know of. So it actually should make you feel safer. It works. And you know that the filler that you're using worked, unless you hadn't primed the needle. So you actually should feel the opposite. So let that percolate. Hopefully you will feel the opposite in the future. How do I decide whether to use a cannula or a needle for a particular patient? So I use cannulas in terms of the particular patient. It's whether they are likely to be sensitive to needles, for example. It can be less painful in certain areas. That might be one reason. Typically, it's more about the area than the patient. So, and whenever I'm using a cannula, I tend to think it's mid-depth. So if I can do the procedure in the mid-depth, so I'm not treating a crease on the surface of the skin, and I'm not trying to create projection like a bone, then a cannula is often the right thing to do. So if you're just replacing volume in a fat pad, for example, cannulas are a less traumatic way to do that for most people. So that's probably the most useful thing. Anything that needs detail or needs a bit more depth, I tend to gravitate towards a needle. What causes filler infection? So infections, just bacteria growing on the filler, but they can come either from the procedure. So you might have a little bit of bacteria on the surface of the skin that gets dragged in. It could come from bacteria that's on the needle or in the something to do with how it's been prepared. So the more stuff happens to the filler before it's injected, so stuff that's mixed, for example, is probably higher risk. Stuff that's changed into different needles is probably higher risk. We don't have any data on it, but it makes sense that it would be. Then it's the surface of the skin. And then the other place you can get infections from is dental infections. So it's been established from decades that even if when you brush your teeth, you get bacteria that enters the bloodstream, and quickly your immune system tends to sort it out. But in theory, it could settle on filler where it's a little bit harder for your immune system to get to it. So some infections come from inside and some come from outside, and which we don't really know. But it's worth knowing that even if you do everything right, you could still have an infection. Probably the riskiest infections are the ones around the riskiest place to inject are the ones around the mouth, because we all know mouths are dirty and you've only got 2 millimeters. Even if you're staying on the dry side of the wet dry border, it's so close. It only takes the patient to lick once, and you end up with bacteria being exposed to that still open, tiny little hole. Yeah, as someone has said, there's lots of factors outside of your control. That doesn't mean you shouldn't make the most of all the factors you do control. Someone has said that they will not get tear troughs again because they're always lumpy. So just remember, with lumps, there are two main causes. One is the injector is injected too much, particularly of the wrong filler. So tear troughs are very, very sensitive to using the wrong product. If you use a standard product, I've seen lots of people do this. They just treat it like another area to inject, and they inject a little bit of filler there, and it's too firm a product. You get away with nothing with tear trough. So it could be the wrong filler. It's actually three ways. It could be too much of the right filler. So the other thing about tear troughs is it doesn't take much for it to become visible and lumpy, because the skin is only 0.2 millimeters thick. So a lot of newer injectors, and I used to be a newer injector. I wasn't born like knowing how to do this stuff, and I had more problems at the beginning when I was injecting, but basically a little bit heavy thumbed, as we call it. Getting it right on the day, a little bit of swelling, and you can see the product. You get away with nothing. That's why there's a problem here. And then the third one, not to rule out, would be not to forget, would be that you've actually having either a reaction or an infection. Reactive products are more of an issue. So things that cause your immune system to send some white blood cells to the area to start to react to the product. You start to see little bits of filler. You can get rapid ones, which are kind of red and inflamed, but you also get this more chronic type reaction where the filler just gradually goes hard. And I don't know for sure what's going on, but I just imagine there are white blood cells going to the area. They're releasing inflammatory agents slowly, and you get a little bit of collagen that encases the fillers. And over time, you'll meet patients from decades ago who've had hyaluronic acid fillers who have little nodules, not even only hyaluronic acid, but it's anything that reacts slowly, like a slow burning reaction. You get lumps. Those are probably the worst ones. And I'd say the most common reason people get lumps in tear trough is just simply because a bit too much filler has been placed. And it takes practice and time and a little bit of healthy fear to not cause that. So you need to be injecting as little as you possibly can to get a result, not going for a perfect result, as they often say. But if you're always getting the same thing, then I would consider it could potentially be that you're a little bit reactive to it if it's not the wrong product. Do you need to aspirate when doing lips? So aspirating, it's really important to understand that aspirating is a way of gathering data, and it's particularly useful when you don't have other ways of gathering that data. So although I'm a big proponent of aspirating, you can be safe without aspirating. It's not like a religion. It's simply a step that gives you some information. So if you know where you are depth-wise and you've checked the area carefully, it's perfectly possible to do a whole procedure in lips without aspirating, but you must be doing other things too. You can't just inject and hope it'll be all right. One of the ways to think about safety in aesthetics is to think about the order in which you do things. And conceptually, you should be primarily trying not to cause a vascular occlusion, while secondarily doing a procedure that gets you a beautiful result. I think most of the more risky injectors are primarily trying to get a beautiful result, and fingers crossed they won't get a complication. So it's that way around. If you go into a procedure and you've planned how to do it with thinking about safety first in every single step, then I think aspirating is one more thing you can do. But I wouldn't say it's the only thing you can do. The question is, how sure are you by elevating your needle that you're not in a vessel? How sure are you by what you know about the anatomy and where the arteries tend to be that you're not in a needle? How sure are you, based on the examination you did of the patient before you started, that there isn't any major vessels there? If you can say all of those things that you're sure, you could make the argument that aspirating is not going to add a lot of additional safety for it. If you are somewhere where any of those criteria don't play out, it might be worth aspirating, because that gives you a little bit more chance of getting that important information of where the filler is, where the needle is, before you actually inject. Okay. Should we inject hyaluronidase directly into a vessel or around it? So this is a really interesting thing that's happened recently. There's more. I'm sorry, trying to adjust my YouTube camera because I can just see I'm talking off the screen. Sorry about that. So this is something I've seen more and more discussion around. This idea that if you can place your needle into the vessel that's blocked, that should be better than placing it elsewhere. Now, there's lots of stuff to unpack with that particular claim. The first thing is, how much of what you're doing in that case is actually unblocking the filler, and how much is just flushing it through the system. And flushing it can be great. Like, maybe that's a good thing to do if you're flushing it in the right direction. Maybe it's the worst thing you could possibly do if you flush it in the wrong direction. Now, unfortunately, these cases are never published, but I do know via someone who's inboxed me on Instagram of a story of a patient who lost some of the vision in their eye, went to an accident emergency department, and it was then flushed with saline, and then he got central nervous system problems. So this is one of the issues with the blindness protocol, which I've seen discussed, is if you have a column of filler in your supratrochlear artery, and then you inject some saline into that area, even if there's hyaluronidase in it, and you flush enough, where is that being flushed into? There's only one place. It's being flushed into the nervous system, into the central blood supply. So your internal carotid blood supply, it's supratrochlear artery, down into the ophthalmic artery, and then you're basically in the central nervous system. So I'm very let's just say I'm very uncertain that that's a good thing to do. I don't think we should be routinely looking for the vessel and flushing it when we're close to the central nervous system. Now, that might be different if you're somewhere else, but it's rarely going to make things better unless we knew that hyaluronidase dissolves filler in seconds. I don't think it does. I think even when you put it in a petri dish and you squirt hyaluronidase in, it takes some time for all those fragments to actually be dissolved. I think, especially when you're talking about eyes and brains, it's not going to be long enough. In my opinion, it's not going to dissolve the filler quickly enough that you should be flushing it in. I prefer the idea that it permeates in from the outside, and we know that has been tested, certainly in animal studies, and that's basically how most vascular occlusions are dissolved, is the hyaluronidase permeates through the vessel wall and dissolves it from the outside. So that's basically what the argument would be, like, which way is it? I think a column of filler where you're injecting hyaluronidase, and even if you didn't flush it, it's not really going to have much surface area to work on. So I would never rely on that as the sole means to dissolve vascular occlusion. I would start by flooding the area and letting it percolate through the vessels. And perhaps if I was really struggling and not getting anywhere, I might try and put a little bit into the vessel as a different way of doing it. But let's just say there's very little evidence on how good an idea that really is, whether we're just flushing it and washing the filler into other places, which could be worse places, deeper and harder to get to, or whether we're actually dissolving it with that method is currently unknown. Would retrograde injection technique for filler minimize the likelihood of vascular occlusion? So, likelihood and severity are two different things. So, if you are injecting a retrograde linear thread, then what you're saying is your filler is being spread over the path of the needle, which means that you have a higher chance of crossing a vessel in that path, but the size of that vascular occlusion will be smaller because you're not putting a lot in one place. And that's the battle that we're always up against: is its severity versus frequency. So I don't think a retrograde thread on its own minimizes the likelihood of vascular occlusion, but it probably means you can have smaller vascular occlusions than if your needle's all in one place. Um, that depends. That also depends on where you are. So a retrograde linear thread near the surface of the skin, if you're just treating a crease, you know there aren't very any named arteries in that area. It's really quite unlikely that you're going to cause a vascular occlusion at that depth. But a retrograde linear thread, right up here, for example, doing the nasolabial fold, that makes it more likely, from what I understand of the anatomy, than if you just stayed deep and done a bolus, maybe aspirated in between, maybe moved the needle a few times, but you're staying at the same depth. So it really depends on multiple factors and where you're injecting. And think about each area, the arteries in that area, and try and make a decision based on those factors. Would I advise aspirating on every injection? So I have touched on aspirating already. I think a reason why a lot of people don't like aspirating, and this is just my opinion, but I think even those who advocate against it, is because it's a chore. And the reason I train my trainees to aspirate every time is because that's how it becomes less of a chore. You get very good at it. You can do it almost in your sleep. I can do it very quickly. So I recommend that you start out aspirating all the time, and then over time, you only aspirate where you are uncertain of the other measures that you've taken. So I don't aspirate now on superficial creases, for example, or various other places where I know I'm safe. How soon can you identify a vascular occlusion? I think the majority of them, if you test quickly, if you're doing capillary refills all the time, you'll get before your patient leaves the clinic. And at Skin Viva, I think we're on to about 19 vascular occlusions in the whole time we've been running that business with 8 different clinicians at times. Every single one of them was diagnosed before the patient went home and treated. So we've never had an injury from a necrotic injury from a filler. So that's the key. Is if you and that's quite a large data set. I mean, we treat, I think, sometimes 2 or 3,000 patients a year. And if we've never had a vascular occlusion that's become necrotic because they've all been diagnosed immediately, that's very reassuring for clinicians that if you do these safety checks every single time, you will pick up your vascular occlusions early and you'll have a chance to prevent them. So the answer is you can identify them within minutes, I think. I'm sorry, that comment's too much. I can't read it out. Um, does hyaluronidase make patients itchy just where injected as an after effect? I think it does. I've not seen it as a major. I've certainly had patients with a degree of that, a little bit of irritation. So I think it's. I wouldn't say it's all patients, but I have heard that. What's the riskiest area to inject? So riskiest area has got to be bridge of the nose, because it's so close to the internal carotid blood supply, blindness, stroke, and because we use relatively large areas. So I think I would, in terms of frequency of vascular occlusion, it's not there. It's lips. There are more vascular occlusions in lips than noses. I'm sure of that, but they're easier to diagnose, and basically they're further away from things. So it depends how you define risk. If you're afraid of having VOs, then all filler can cause it, but you're most likely to have a really significant one that affects someone's life if just injecting the bridge of the nose. However, there are many, many, many things you can do that will not make it a 5-minute nose job, but you can do in addition to the other safety steps that still make it safe enough to do for a well thought out practitioner. And I'm not someone who thinks just because it's number one that you should never do it, because then there's just another number one you're going to have to worry about later on the list. Even a nasolabial fold can cause all these side effects. And if you're going to do aesthetics, the best thing is to study the anatomy and think of an injection strategy that lowers the risk, not just never do it. Okay, I'm going to scroll right down to the bottom. I think I've had quite a few. Let's have a look. Layla, by the way, is dropping. If you do want to, because I mentioned that webinar earlier on some of the things you can use, basically how to harness this energy that you've all got to be safe and plug it into actual activities you can do in your clinic on a day-to-day basis. I'm doing a webinar tomorrow night on that. If you've not already seen that webinar, it's a really good way of channeling your energy in the right direction so that you can actually become safer straight away with practical steps you can start doing tomorrow. Okay, let's have a look. So someone else says, should we aspirate at a certain point and how many seconds? So once you take the position that the information that you get from blood entering your syringe is probably correlated somewhat with the proximity of a vessel, because not everyone thinks that way about it, but that's the reason you aspirate, because the data is useful. You should know your product. So this follows on from believing that there's a correlation between blood in your syringe and the proximity to vessels, is you try and think of, how do I make this more sensitive? And one of the most obvious ways is to know your filler. Some fillers do not aspirate. So if you aspirate for 20 seconds, you still get nothing back. And you need to know your product. So I suggest you save a bit in your syringe. Tiny amount is all it takes. Put it into your needle and see if you can aspirate something like milk, which is the same viscosity as blood, and see how long it takes to come back up the syringe. Now, that's not a perfect, like, it'll always work in that amount of time experiment, but it will tell you about the products that don't aspirate, and there's no point. So Juvederm Ultra 3, if you use that with a 30 gauge needle, there's no point aspirating. It will never, once you've primed the needle, it'll never come back up in a reasonable amount of time. That's very useful information. Then you need to use other steps to make sure that you're safe in addition to whatever else you normally do. So, but likewise, if you use certain products, you'll be amazed. Some of them will aspirate within half a second reliably. And that's a very useful thing to know, because that tells you if you do a 2-second aspiration on your patient, that's more than enough time. So know your product is the most important thing. How long does a vascular occlusion typically take to treat? This is very, very helpful question. So one of the things I've noticed reading many, many papers on vascular occlusion is the number of times where they will present a patient who's had a nasty injury. They'll literally show the necrotic injury. And in the case report, it quite often says hyaluronidase injected with immediate relief. But the patient is covered in necrotic injuries. Now, it doesn't make any sense to me that you can inject hyaluronidase and expect it to immediately dissolve the filler. I can't do it in a Petri dish. I've never seen it happen in real life. I've seen it with tear troughs, very old filler has gone baggy, and then you inject some filler and it seems to dissolve within, I'd say, 2 or 3 minutes. You can tell that the product is leaving. But that's not a vascular occlusion. I think you should not expect any difference from a true vascular occlusion from injecting hyaluronidase, maybe unless you flush the vessel, which causes other issues. But in terms of dissolving filler in a vessel, you're not going to get that within 45 minutes. And that's really helpful information, because one of the things I realized as when I had my first vascular occlusion is I had this idea that it would be quite quick. And when it got to 45 minutes, I was really getting really stressed out. And back in those days, I called Fabiquisi, who I recommend. He was the first person I could think of helping me, and he was very helpful. He saw the patient. I will always be grateful to him for that. That was like more than 10 years ago now. But that was a learning experience, because I had an idea in my head it was going to be done in 10 minutes, and 45 minutes was how long that one took, and that was quite small. Now, the next one I had in our practice took an hour and a half. And I've now also seen one that took approximately 8 hours. This happened in Germany. It was a skin booster with a cannula. I think it was quite a lot of product. And that ended up taking about 8, I think it was actually more than 8 hours, but it took many, many hours to get it completely back to normal. And that's helpful to understand and to prepare yourself for, and your patients. Like I said, my webinar talks about this in much more detail, because these stories are what you need to absorb in order to actually become confident in a real situation. The information kind of gets scrambled in your head quite quickly if you haven't sort of internalized these stories and belief systems, and you can start to play out the different varieties of the elements. So, what it looks like, how it feels, what it's like actually going through the process, and how long it will take is all very, very important, so that you can navigate in amongst the chaos of these situations. The other thing I talk about a lot in this webinar is the chaos that comes with real people as opposed to case reports. The case reports, they are sanitized. There's no mention of, the husband who gets fed up, and or the, I had one where the wife was trying her best not to let her husband know that she had filler. So she was trying to get me to say, it has to be, can you just say that it was some sort of vitamin drip that's causing this problem? And I was like, I don't know, I don't know how to do this, how to make it like a vitamin drip side effect. But that's the kind of stuff that gets in the way in everyday life that you don't see in the case report. And it actually makes decision making harder, and it can cause distractions, and you can get the wrong diagnosis or undertreat because of the case noise. So very important to understand that. Okay, once someone has been treated for a vascular occlusion, when can we attempt to fill the tissue again? So this is interesting. There are some people who will never treat someone who's had a vascular occlusion again. And there could be some rationale for that, because if they get another vascular occlusion, the psychological injury is going to be worse because it feels like it's really bad luck. But I actually think if someone's had a vascular occlusion and you were doing it, and you know exactly where that vascular occlusion occurred and which injection, and you don't do the same thing again, in some ways you could say that they are less likely than your typical patient, because you at least know where one of their blood vessels is and you're less likely to cause it. So I don't consider it a contraindication having a vascular occlusion just because you've had one. I think you can have another treatment whenever you want to. Bearing in mind, you want the hyaluronidase not to be in the system. So hyaluronidase half-life, it's varied. I think people are saying it's around about 5 hours now. Normally, we say 2 weeks between procedures. I would suggest 2 weeks is quite a nice amount of time for someone to go away and think about it, and to come back and have a retreatment once they've really thought about the risks and the side effects, just in case it does happen again. Then at least they haven't felt rushed into it. I know there's an increasing trend of treating people even on the same day after reversal. There's no data on that. I think it could get expensive if it dissolves other product. So I'd recommend 2 weeks is a nice safe amount of time to leave between refilling after a VO. Do I administer medications to enhance blood flow, reduce inflammation, and or prevent infection after resolving a vascular occlusion? So there is a tendency, if you have a vascular occlusion, to throw everything you can at it to make, and it's because we're so afraid of this impacting our patients and of being sued and all those things. So it's like, let's put as much stuff as possible so that I've done everything and then I'm safe. And I got some really good advice from a senior colleague many years ago, and who dealt with some of these injuries that occur to patients and in a legal setting. And he told me that it's quite common to get sued for over treatment rather than under treatment. And it's because, and I totally understand it, it's that sense of I want to try everything. I'll give you one example. I once treated a patient with steroids. It was actually for asthma on my GP practice, but she became manic after her steroids and spent thousands of pounds on a credit card because she was basically off her face on steroids. And that, I didn't get sued for that because of who I wasn't to know. It was first time, and it was a life and death situation. But if you treat everyone with steroids, eventually you're going to have someone who has a side effect like that. So the law of minimal intervention should always apply. You should do the least amount that you need to keep your patient safe, not the most amount to prove that you've tried your best. So what that means is if the capillary refill is normal after round after round of hyaluronidase, I don't give them anything other than the aspirin that I gave them when I first started, because I would start the procedure with aspirin, do the reversal. But if capillary refill is normal, I would just keep a very close eye on them rather than putting all the other drugs in. Because you can have them on Viagra and you can have them on aspirin and steroids, and then they get a stomach ulcer and an erection. There's all sorts of things that can happen that you don't need to worry about. So it's better to keep it simple. Keep it simple, stupid, as the saying goes. Treat what you can see that there's good rationale for, or there's a good evidence base, but don't throw everything in the kitchen sink at it. Okay. Would using an ultrasound facial mapping prevent a vascular occlusion? So I have an ultrasound. I like my ultrasound. It's useful to be able to see what's going on. I liken it a little bit to opening up the hood on a car. Like, it's really fascinating to see what's going on under there and to understand stuff on more of a level. I have to also run that with with what my experience has been, which is one vascular occlusion in 15 years. And it makes me just to put both of those things together, you do become a better educated clinician, but it makes sense that it's going to prevent some vascular occlusions because you're seeing more. But it's not the kind of thing that I think we should be saying that you're unsafe without an ultrasound. Just like I don't say you're unsafe if you don't aspirate, because there are many other steps you can do. So the question is, are you doing all those other steps? And the other way I would look at with ultrasound is, because mapping is one thing, but you don't see all the vessels on ultrasound. They haven't got high enough resolution for you to see all of them. You pick up the biggest ones. You can still get a vascular occlusion after an ultrasound, and that could still be annoying at least. Like, it's not like but it will prevent you from I think, these rogue arteries that happen to be on the bone in the temple. I think it'd be nice to be able to spot those before you inject them. Although I must say it's not an area that I see that many vascular occlusions in the grand scheme of things, but it must happen. So I think if you've got the budget for it and you're curious, and particularly if you want to be, if you're going to educate other clinicians, or you're dealing with a high number of complications from elsewhere, then ultrasound is a good investment. It's also a good investment if you are held back by a particular issue. Like if you've had a vascular occlusion and you don't ever inject lips again, it could get you over that problem if you start to scan lips and see where the vessels are. Same with noses. If you're afraid of doing non-surgical rhinoplasty, it could be one of the ways that you could overcome that hurdle and then serve more people. So I would look at it in that way, but I wouldn't suggest that every new injector has to drop 10 grand on an ultrasound before they could be considered safe. There are lots of other ways, other things you can do. Someone says, is it true that it's unsafe to have a non-surgical rhinoplasty if you've already had a surgical rhinoplasty? So there's some things to think about with this. The reason that is a potential issue is because of scarring, means there's less room for the filler to expand, and you may also have a worse blood supply to the nose before you even start. Now, this is because they often tie off vessels and don't untie them, I discovered. So columellar artery is often tied off during a surgical nose job and apparently isn't always untied, so that you have less blood flow to the area. Then you get an addition of scar tissue in the area, which means there's less room for expansion of the product, which means compression necrosis is more likely. I think a sore from pressure is a well-established medical phenomenon. The idea that you could cause it by injecting filler makes perfect sense to me, that you could actually cause pressure on the capillaries that would prevent the nose getting enough oxygen and causing some superficial necrosis. So those are the elements. The way to get around it, or to take it into account, is to test the nose. How mobile is it? This is one of those things that with practice I think makes a big difference, but it's going to be very hard to prove that I'm right on this because it's so subjective. But I think you can tell if there's room in a nose. If you can pinch the skin and it moves off the bone, then you're basically learning that there's some space. Now, I've seen on a course once, I saw someone who'd had 3 surgical rhinoplasties, and she was injected, and it was so adhered to the skin, it was like bubble wrap. This bubble came up where the filler was, and you couldn't move the skin off the bone at all. And the injector immediately realized that there was no way that they could complete this procedure because it was so stuck on. And those are the cases where it's an absolute contraindication. But most surgical rhinoplasties, if the skin isn't scarred, there is actually room. You've just got to do small amounts at a time, monitor it, and check the blood flow in between each one. And I'd be very careful about injecting the tip. I see this even on healthy patients. They end up with a red nose for 6 weeks, more than that, 6 months after a procedure. Because of the pressure. I don't think that should be considered normal. I think you should have a normal nose within 2 weeks. Otherwise, it might need reversal. Okay. Someone says, are you recording this to post on YouTube? Yes, it is actually on YouTube at the same time. So what is my opinion on dissolving HA in the lip and then refilling and taping in the same session? I need to do a whole video on this taping thing. There's a lots of stuff in the taping situation that is implied that may or may not be true. It's a lot like the idea of putting the cotton thread through your mouth and creating the keyhole lip. I think it looks great on Instagram because it's a visual story. It tells patients immediately what the concept is, that you're going to give them these different shaped lips. Whether it actually does that or not is a whole different thing, because you're implying that it's like some sort of cement that goes in with a particular shape, takes a little bit of time, and then sets and then stays that way. And I think there is an element of that, but it's not cement. It's flexible, it's liquid. We all know that you can pop a needle in and squeeze filler out. So the idea that it's going to maintain that shape for a very long time, I think it's unlikely. I think it probably does maintain it for a few hours. But the main thing is it is very catchy on Instagram. And a lot of nonsense spreads because it looks cool on Instagram. Even from the best accounts, they've got lasers and they've got these micrometers measuring, as if you need something that measures an ant leg in order to inject someone's jawline. But these are the things that look cool, and they're communicating something to patients. And this is one of the things I would say you should do, is try and figure out, why are these things catching on fire on Instagram? Because they must be serving some purpose. And what I would say they're doing is communicating to patients certain things that patients value. Like, we have the ability to change the shape of your lips, and this is an extra step, and we can make a big difference. These are the things that patients are looking for. The problem is, when they're not true, then you end up charging patients for things that don't actually do what they say they're going to do. And it's a short-term game. The biggest downside with these things is not what happens on Instagram. It's what happens behind closed doors, when the patient comes back and says, that only lasted two weeks. I want my money back, kind of thing. That's the downside of it. So what are my thoughts on filler migration over time, and that it's never dissolved 100%? So if you I don't know if you've remember the stat being about, like, if you put a teaspoon of sugar into a still cup of tea, it would take several thousand years, but it would eventually be evenly distributed without you stirring it, and that's a still cup of tea. The point is that things do move over time, almost no matter what you do. Like, you can do 0.01 in a lip in someone who doesn't dissolve their filler, and if you wait long enough, it'll be distributed, because that's just how it works. Like, it's just a matter of time and pressure. And the biggest risk, probably the two biggest risks for migration, is the amount of filler injected, obviously the where it's injected, but also the length of time that it lasts. And I think what we really have to worry about is this cohort of patients who don't ever basically dissolve filler. Dr. Masters showed this very well in his publications, that there are patients who have one syringe of filler and 12 years later it's still there. So those are the people who, over time, it's going to migrate, because your face is moving all the time. Just think of, if you just watch someone, how often they touch their face when they're talking to you, and then they're moving and eating and doing all these things. The idea that it's going to stay put is probably not true. What we're hoping is that it slowly dissolves at a sufficient rate that you get benefit, but that it never collects too much in one place. Otherwise, we're going to be in the situation, which I think we are already in, where occasionally you need to dissolve in order to get the best possible result. I think that should be very occasional, like every 4 or 5 years, not every 6 months. But it will. And the other thing about it never dissolving 100%, I think that's true for some patients, but it's not true for all patients. There's a cohort of patients who don't even get like more than 3 weeks. They're a very small minority. It's about 1 in 2,000 or less. I just had someone inbox me recently on it. You inject it, it dissolves. Those patients are never going to have migration, because it's going to dissolve before it happens. But they're a very small number. Your ideal patient gets 6 to 9 months, and then there's this other cohort who lasts so long that you're going to get migration eventually. The most important thing I say about that is we should all be consenting our patients for that risk now, because otherwise you're going to brew up. If it ever hits the media that this is like on a large scale, and every patient who needs reversal is saying, God, that's happened to me, and you haven't consented for the chance that their filler might last for a long time, need reversal, technically you might be liable for that. So I would start building into your consent processes. Someone said, sounds like a patient asking that you had 300 units to dissolve 1 ml. Is that too much? I'm scared because it affected my face. So, I mean, that is basically nothing in comparison with a vascular occlusion. There are many cases of vascular occlusion where they've put in, let's say, 15,000 units would be possible. So 300 units is nothing, and most of those patients will do not complain of anything happening to their face. Now, I know there are kind of groups and people who feel like it has affected them. We have to keep an eye on that story, but if it's like a lot of these things, even if it is true, it's a very small minority, and I've never personally had any of my patients affected. There are people who I've met who say they've been affected. It's very hard to judge, looking at the before and afters, whether this really is something that's as bad as it seems. I've never seen certainly anyone who looks like they to the untrained eye like any different from anyone else. So I don't think you should be scared by it. It's not a very large amount, and most people are not affected in any way in the long term. Okay. Do I still follow the protocol of 1 mil Hyalase to 2 mil saline? Yeah, I mean, there's no perfect data on this. So a lot of the time, if I change from that, or if I recommend people change from that, it's because they don't have enough hyaluronidase, and I don't want them to inject it all too quickly. If it hasn't got a very long half life, we need to be staggering the product that you have got so that it persists over a few hours, not just 5 minutes. So 1 mil and 1,500 units is fine. 2 mils and 1,500 units, I think, is fine. I don't think there's technically a huge amount of difference. 1 mil is probably what I'd go for if I have a cupboard full of hyaluronidase. The more concentrated, it seems to me, the more likely it'll work quicker, because it's that simple concentration gradient, things by osmosis. You're trying to get this to transfer through a vessel. Then I want to have a high concentration next to the vessel, which means frequent concentrated boluses of hyaluronidase in the area that I think is occluded. Some of these are kind of visual questions I can't quite picture. So someone is complaining of hard pea-like lumps on the face that haven't gone away in over a year, and hyaluronidase does not work. Do I have to have surgery to remove them? So these sound like delayed onset nodules. If effectively, it's likely that whatever your body was reacting to, could be bacteria, could be filler. It sounds like it's the filler. It has become encased in collagen. These collagen little cysts, and they can be very hard, do not allow hyaluronidase through very easily. So dissolving them doesn't work. Now, you could potentially put a needle into them and squeeze the contents out. Occasionally, you get benefit from that. Or you can wait. I've had one patient, had been having filler since I was pubescent, so a very long time, and she had lumps in her lower face. I treated her for about 7 years and doing in other parts of her face. And on about 6 or 7 years in, the filler lumps that she'd had when I first met her had disappeared. And that was kind of reassuring, but they were there for at least 13 years. So they do remove with time. In some people, they might soften with time. Otherwise, yes, possibly you need to have surgery if you think it's worth it to have them removed. What size cannula to use? I'll answer that because it's quite straightforward. 25 gauge does most things. I do use slightly thicker ones for certain procedures that are longer, and thinner ones. 27 gauge is the smallest I'll go through, but I'll be very gentle while using that. Oh, there's so many I'm not going to get to. Thoughts on using ultrasound as a form of safety for lips in particular? I think if you depends how you inject lips. If you're staying in the anterior compartment, which most of us are these days, and not doing large boluses in the body of the lip, I don't think you need an ultrasound to know that you're not in a vessel. I think you're close enough to the surface with elevating and and knowing your anatomy that it's unlikely that you'll ever be in that place. I mean, I know it's very anecdotal, but Julie Horn must have done tens of thousands of lips. She doesn't aspirate. She's never had a vascular occlusion. And I know why, because where she injects is the least likely place that you're going to find a vessel while injecting the lips. She's very, very precise. And that for me is the key, is become precise, know your depth, know where the artery is, and do the other steps. Check for the artery, physically look for it, do little depth checks, and you don't need to have an ultrasound. I don't think it'll. I don't think it would. Having said that, I'm going to be like, obviously, I did have a vascular occlusion, in the one I had was in lips, and it was one in one of the variants of lips. You can get about 1% of people who have a more superficial vessel. It's on top of the muscle, so potentially it could have prevented that if I scanned them. So I'm not going to say it's not going to prevent vascular occlusions. It's just don't forget there are lots of other ways you can do it as well. If you've got the budget for it and you're interested in these things, then you should go for it. Have I seen any vascular occlusions with skin boosters? Yes, I have. So I absolutely believe you can get vascular occlusion with skin boosters. You can get vascular occlusions with PRP. You can get vascular occlusions with steroid injections. A lot of companies will tell you it's impossible to get a vascular occlusion. The only way that would be possible would be if the stuff you're injecting does not cause blood clotting in any way, so it's not likely to cause the blood to trigger a cascade of clotting, or it's thinner than blood itself. And I think there's a lot of these things that are like, you can even cause a vascular occlusion with air, for example. So don't believe the hype. Always, when people say it'll never cause a vascular occlusion, PRP used to be one of those things. There's now a case of blindness from PRP. So it is possible. It's just unlikely and less unlikely, but you should always just assume that in some rare cases it could, and inject in a way that reduces the risk. So I have seen one from that. It's on my complications program as well. It was a skin booster. Okay. Oh, time flies when you're having fun. I didn't realize I'd gone on so long. So let's do a couple of other. How much hyaluronidase do I inject to dissolve filler that is not related to VO? Well, you try and use the minimum amount that you think will dissolve the product. The formula that people tend to use is about 100 international units of hyaluronidase per mil. Now, the problem is all these fillers are different, and you never know exactly how much filler is there, and so it's not a perfect situation. But I would try and use. That's what I try and do if I'm trying not to dissolve all of it, and trying to be careful with the amount we use. And thoughts on Russian lip filler technique? Is it just a gimmick or really a different technique, and is it safe? Well, it's worth stating the actual technique itself it varies by injector. Like there are lots of different ways of. It's more of a result in many ways. But the technique that is most common is the vertical injections that cause the arch. Like the Russian doll lips, if you look at them, they've got angles on them. That's how I think about Russian lips, is they're about creating angles. And you absolutely can create different angles with different techniques. Now, it's probably not as extreme as you'll see in some of the Instagram pictures long term. I think that when you put too much in it, I don't think it holds that much shape. But you can absolutely, with a vertical injection in a particular shape, create more of an angle. So I don't think it's just a gimmick. I think those different injections cause different results, which is what we'd expect, really. Whether it's all that it's claimed to be is more subtle. Okay. Have I ever seen a case of hyaluronidase-related anaphylaxis? I know of one through my network, but I've never seen a patient myself who's had that. I've had patients get what looked like starting anaphylaxis. I had one of my members of staff who'd had a actually fairly negative. It was slightly pink intradermal test, but she swelled up, lower face, looked like the guy from Bo Selector, enormous swelling, and he and she. That was scary for us, but we just treated it in the clinic with steroids and antihistamines, and it went down within like 45 minutes. So it wasn't true anaphylaxis. But I know of one person who had a patient admitted with full-blown anaphylaxis from it. And I know of it's one of these things, I wish I'd kept her name, but someone who works in a cancer specialty, and they use hyaluronidase for various drug dispersal reasons. And she said they'd had anaphylaxis multiple times from it. They don't even consider it that rare. But they use much larger doses, and that does make a difference. The published data I last saw, which was a while ago since I looked, was about 1 in 2,000. So I think you should consider the context by where you inject and how safe you feel if you were to have that reaction. And most of us, certainly most aesthetic practitioners in the UK, are not very well prepared for that. So that's why I recommend additional measures like the intradermal tests make sense to me, even in a vascular occlusion setting. Because I know one patient who I'm pretty sure would have had anaphylaxis who I tested because she was allergic to multiple other things. And when I did an intradermal test, it swelled up like a bad bee sting. It was huge. And I know if I'd put 8 vials to rescue her from a vascular occlusion, that very likely would have caused an anaphylactic response. And I think that information could be useful. Okay. Great. I think I'm going to wrap up now. So don't forget, Layla would have dropped into the comments on both YouTube and Instagram. If you want to come to the next webinar I'm doing, which is tomorrow night, and it is on how to get away from the anxiety of complications. So clearly, all of you here have a lot of energy. This webinar describes exactly how to implement and use that energy so that you actually get over fear of complications faster. If I can help, because I have this theory that the people who are most afraid of complications should be the ones doing most of the procedures, but it's the opposite, isn't it? It's the people who are least afraid, most confident, who are probably okay to do all the risky procedures. I would rather get all the scared people and teach them some methodologies that they can use day to day that give them the confidence to implement safer practices so that they can do the riskier stuff, because patients will be safer when the scared injectors are injecting than when the non-scared injectors are injecting. So if you're on that spectrum and you worry, like I certainly was a lot in the beginning, then make sure you check out my webinar, which will be dropped in the comments down below, and that should help you. Okay, guys, I appreciate all the questions. Lots of fantastic questions. I went over more than I thought I would, but I really appreciate your time. Someone's asking for the webinar. The webinar is at 8 p.m. UK time, and Layla will drop the comments, drop the link in the comments. It's a free webinar. Everyone can join. They're also on my Instagram stories, Layla says, and there'll be a link in my bio as well. So yeah, check out my Instagram stories, or if you're on YouTube, I don't know if we can drop the link in the YouTube comments there, but Instagram stories is the first place to have a look straight after this. I appreciate your time. Hopefully see you somewhere in real life soon. Thank you, everyone. Bye-bye.